So my name is Norm Buckley. I'm the scientific director of the Institute for Pain Research and Care here, just around the corner, which is the research side based at McMaster University, affiliated with the DeGroot Pain Clinic, which is on the hospital side where most of the clinical activity happens. If anybody who's seen me before knows that you have to put up with an obligatory ad for my band, which actually has a concert in Hamilton in a couple of weeks, playing at the Scottish Rite Cathedral on Queen Street. If you watch Murdoch Mysteries, you will have seen various parts of the Scottish Rite Cathedral. But it's actually a fun band. It's a British brass band, and we're doing a concert in the afternoon on Sunday with a guest trumpet player, quite an accomplished jazz trumpet player from Toronto, which is a real bastion of excellent music. So if you wish, it should be a fun afternoon, and it's not even terribly expensive. What we're going to talk about this afternoon, is the Canadian Pain Task Force, a bit of the background to it. And those of you who are involved in Royal College specialty training programs or undergraduate medicine in particular, part of the evaluation process there is your understanding of engagement in advocacy. And a lot of times in clinical training programs, we drive the advocacy down to a very basic, are you looking at a single patient, trying to see that they have access to the optimal care? In this case, I want to talk about something that has been going on really for probably 15 years, and we're now seeing its manifestation in changes in national healthcare policy. And it is ridiculously exciting for people that have been involved in it, and I think it has profound implications for pain care and research in the country. In terms of disclosures, right now, I can think of nothing bad to say about either Veterans Affairs Canada or the Canadian Institutes of Health Research, and none of the pharmaceutical companies have come even close by several orders of magnitude to influencing my judgment in the way those two groups have. So I am beholden to them. Speakers' fees go to the education fund. I've done some consulting. I have been in this business since 1987 at least, so have watched some of this unfold, and certainly definitely contributed my own share of complicating factors to patient care throughout that time. And the talk is cribbed together from several other talks. If you are submitting for educational credit for your continuing education, this is the attendance code that you put into the ETA notice that you received when this was when the rounds were announced. ETAPZNG, and then that your continuing education credits will be forwarded to you. Got it? Great, thanks. So the background here is that about 2 years ago, or throughout 2018, Health Canada officials started meeting with pain stakeholders to understand the issues and challenges of people living with pain. The driving reason at that point was just the background of the drug-related overdose crisis. And subsequently, in the fall of 2018, the Health Canada hosted an opioid symposium, and there was a roundtable hosted by the Minister of Health. And then during the symposium itself, several sessions on chronic pain and opioid use. And then in her closing remarks at the opioid symposium, the Federal Minister of Health announced that they were going to consider options for a national pain task force. And then in March of last year, the Canadian Pain Task Force was announced. That task force, though it sort of came to fruition fairly quickly, is actually the result of at least 10 years of work. What I want to do is present a little bit of the background to that also a very brief and simplistic discussion of how healthcare policy is developed and implemented, some of the history of the initiatives which led to this Canadian Pain Task Force, frame them by discussing some other health policy initiatives which are important, some of them in Canada, some of them internationally, and also just draw your attention to some of the people that were involved in this, because their work was key. So why would we want a Canadian pain strategy? Those of you who deal with chronic pain patients on a regular basis, you know how common it is, 20% of Canadians. You also know that in many cases, the medical model, sort of simplistic identification of the problem, diagnosis, implementing a treatment, having everything go back to normal and life goes back to normal, doesn't really work for the problems that often are associated with chronic pain. We also will be well aware that by and large, it's still the case that healthcare professionals across all professions, medicine, nursing, pharmacy, physiotherapy is probably more equipped to deal with the intricacies, and the rehab sciences in general are more equipped to deal with the intricacies of pain care, chronic pain care. But by and large, healthcare professionals are not adequately trained and don't understand the background. And the other issue is that in a strategy, one needs to incorporate patients and patient organizations, because for a variety of reasons, both to ensure that your strategy is correct and also for the level of public support necessary to drive towards a strategy, you need patient organizations involved. It's significantly costly. The various estimates in Canada run as high as $60 billion a year. In terms of changing policy or getting policy directed towards these things, there are some things that need to happen. So you read in the papers when a new government takes office, or when a government begins its policy-making year, you hear a speech from the throne which lays out what the goals for that government are for the year. To get onto that goals list, the throne speech, you have to get some sort of priority status. So your subject or your problem or the topic or the area of interest has to get some priority status. And you get into that decision agenda either because of a problem or because of a policy stream or some political driving that's happening. That decision agenda is then presented by a policy entrepreneur, and you need political champions. So it's an interplay between identifying, in the health case for sure, it's identifying health problems, finding out who has the knowledge, how do you define the problem, is it a big enough problem to hold your attention, can you offer a solution, and then how do you get the right people involved. And one of the things you never do or can never do is go to politicians with a really bad problem and no clear solution, because they will burst into tears and never speak to you again. It just doesn't work. Again, we're back to the chronic pain as a problem. So we say it's a very expensive problem, but nobody really understands it. If you ask people about pain, they know that their pain is real, but they're kind of suspicious that most other people's pain is not real, or it's feigned somehow, or it's a goal-oriented solution. The opioid crisis drew amazing attention to the problem of chronic pain. Even if we assume that there was prescribing that was inappropriate either in the target population or the doses, virtually every opioid prescription was written because of a patient complaint of pain. So it really speaks to the extent of the problem. In trying to respond to the opioid crisis, where patients were dying because of opioid overdoses, a simplistic solution is to say, don't put opioids out there, restrict them somehow, don't prescribe them so much. That's not conducive to solving the problem, because you'll talk to patients with chronic pain who actually have experienced significant improvement with opioid prescriptions. Removing that treatment from them has caused significant difficulties. The other problem is that what's considered optimal care in the eyes of most chronic pain clinicians is actually an interdisciplinary approach, which incorporates pharmacology as well as behavioral sciences, as well as rehabilitation processes and instruction and care. And those programs are limited. and there's not general access to those problems. And in addition to that, then you have the usual, Canada is a big country, lots of places don't have access to all sorts of care, and if it's complex care, the access is even worse. So the reach and impact of existing chronic pain programs is limited. From a policymaker standpoint, there's nobody they can go to and get advice. There is no single organization in Canada that represents pain clinicians, pain researchers, pain educators, and pain patients that they can go to that have a coherent strategy. Pain care is kind of fragmented, and planning for it is episodic and frequently local. Because it's not well coordinated, we can't benefit from scaling up excellent programs and providing economies of scale. And there is no real process for coordinating action. So kind of a nightmare from a policymaker, political decision maker standpoint. If we had a national pain strategy, what might it do? Well, all of the things that are here. You might improve care. You might particularly drive chronic pain care out to the primary care level and the community care level where it can be most effective. You may be able to prevent some sorts of chronic pain or educate people better about chronic pain. And you may be able to, with proper understanding, avoid some of the problems that we've seen with things like opioid prescribing. And we may come to see with cannabis prescribing also. That's another little nightmare in the offing potentially. A national pain strategy could improve research and implementation, the knowledge translation of existing research, and then coordination of the whole process. To do that, one would need to create a coordinating task force. So one of the things that happened was the Chronic Pain Network. Oh, that's interesting. Sorry, I did this. If we back up to the Canadian Pain Strategy that was first implemented in 2011, first presented in 2011. In 2012, on April 1st, there was a meeting and that brought a policy document forward to a national pain summit on Parliament Hill in Ottawa, April 24th, 2012. There was widespread endorsement from across the country. The plan was that that would then immediately be taken up by the Federal Minister of Health, and you'll see because there is a red X and not a green check beside that, that didn't happen. And because subsequently there was to be a year later funding for a national pain strategy, that also didn't happen. So what was the issue in terms of the national pain strategy in 2012? Sorry, there's been a little, a little glitch in the force here. Okay. So why is there a task force now in 2019 and there wasn't one in 2012? Several things happened which I think are critical. One of them being the creation of the Chronic Pain Network, which is a 5-year, $25 million effort, $12.5 million from CIHR, $12.5 million from matching research institutes. Something called the Canadian Pain Care Forum, which we created here, which is really an advocacy group, and also working with the McMaster Health Forum. So, what are these things? The Chronic Pain Network began as an outgrowth of the what's called the SPORE, Strategies for Patient-Oriented Research program at CIHR. So that was announced in 2009, and a number of things were put in place, including provincial SPORE support units. A few years later, as a result of the work of the Canadian Centre on Substance Abuse, the first Do No Harm strategy was released. So this was a really broad-based national recommendation about how to approach the opioid crisis. And the thing that got lost in the translation was that 50% of the directives were towards pain and chronic pain. What got picked up was the idea of treatment around addiction and restriction of opiate supply. But this document was quite extensive and made a series of really excellent recommendations. Interestingly enough, in 2015, when they announced the competition for the creation of chronic disease networks, CIHR agreed that chronic pain had many of the manifestations of a chronic disease state and therefore could be considered as a candidate for one of these networks. We were successful in our application to create the chronic pain network in 2016, and it took about a year to really operationalize things, but we've been distributing funding since 2017 for chronic pain research. So what is the Chronic Pain Network? Is a national collaboration of patients, researchers, healthcare professionals, educators, policy advisors, and the goal basically our single stated goal was to change the face of pain care in Canada. Increasing access, trying to speed up knowledge translation for pain. It's led from McMaster University, but really when you look at the principal applicants, that's a who's who of pain research, not just in Canada, but in the world. And we have 26 partners across the country, research institutes, local researchers, industry, a variety of people, and this is actually why it was a one-year delay. We had to write 26 collaboration contracts and get them all signed before we could actually flow money out. But if you look at this list, it's a very representative national list of research institutes and clinical care professional organizations. And the Chronic Pain Network is a national network. We have, these were all those 26, the red pins are where the 26 partners are. We also have patient partners engaged. This is the part of the strategy for patient-oriented research, is integrating patients into the whole process. And in fact, we have patient partners who are co-chairing all of the governance committees on the Chronic Pain Network, and also integrated into the actual conduct of each of the research projects. So that's the Chronic Pain Network, which didn't exist in 2012, but did exist in 2016. The Canadian Pain Care Forum, which I mentioned briefly. So this is a thing, you will recall that every 4 years, roughly speaking, we have federal elections. So in 2015, there was an election which resulted in a new federal government led by the Liberal Party. And there was quite a change in the readiness of the bureaucracy within Health Canada to entertain discussions about a number of things, including approaches to the opioid policy or opioid crisis. There was also a lot of organizations that were interested in pain, in part because of the opioid crisis, and but in part because they were already engaged in pain work, pain research. And so in the first quarter of 2016, we began to create this group. We started with about 12 or 15 people representing different organizations, but all the organizations that were part of this, they wanted to get pain on the public policy radar. We needed to educate policymakers and the public. We needed to have a balanced discussion about the issues to do with pain in the context of the opioid crisis, and not solely be driven by the real fear, which is, it's a real thing. I mean, there is a real fear about the impact of opioid use, licit and illicit, on the health of the population, but it wasn't driving a solution which addressed the needs of patients with pain. So what we set out to do was provide a forum where these groups could get together, try to ensure that we were pushing in the right direction, educate both the members about what was going on, because that's one of the pieces of knowledge translation, is people just not being aware of what's happening in general. And also, try to coordinate and focus commitments. Everybody that participates in this forum is volunteering because it fits into the goals of their organization or their own personal goals. And currently we have 79 members representing about 45 separate organizations. We have several clinical centers, as you can see there. But we also have members from law enforcement, the insurance industry, and media. We have correspondents or members from various forms of government, local, provincial, and federal. As you can see, several other research networks. There's health professional and regulatory bodies. FEMERAC, the Federation of Medical Regulatory Authorities of Canada, is the national body which represents all of the medical colleges, the regulatory colleges from the provincial levels. We have several colleges which participate as well as their representation through FEMERAC. We recently added the dental surgeons and the dental colleges. You'll see healthcare professional, you'll see the College of Family Physicians represented there, Association of Faculties of Medicine of Canada, ISMP. Recently added the ECHO group, which is a distance education program and clinical care program. And a variety of healthcare organizations, as you can see there, including most recently the Ontario Chiropractic Association and the Canadian Physiotherapy Association. Several other hospitals and clinics. We've added 2 of the community pain clinics. Pain Care Clinics is a chain of freestanding pain clinics, mostly in Ontario right now, and Centers for Pain Management is a national chain of clinics. Patient groups, including the Canadian Injured Workers Alliance, and right now we have a correspondence with the Canadian Labour Congress, who have expressed an interest in participating in the group, and I think would be a very powerful ally in bringing these interests to government, and several Indigenous communities that have engaged in this process also. We meet roughly quarterly. And in fact, our next quarterly meeting is tomorrow morning. We'll be having an update with the Canadian Pain Task Force, and also they're soliciting information from this group about how to proceed with some of their questions. The other group that I mentioned is the McMaster Health Forum. One of the things about being at McMaster sometimes is that you really have no idea what's here until you bump into them or look. And so the McMaster Health Forum is led by John Lavis. It is it's a research and consultative team which works to bring structured, high-quality information around the consideration of critical health policy issues. If you go to their website there, you'll see the variety of things that they do. But one of their services, in addition to doing, say, rapid recommendations to inform healthcare decisions or providing informational support, is to produce what they call deliberative dialogues, where they bring together 20 people in a room and they have a discussion about a complex policy issue. It's backgrounded by what they call an evidence brief, and typically they make several policy suggestions which are debated by the group and try to come up with the pros and cons of each of these so that they can be presented to a policymaker. So you saw in some of the background under the, excuse me, back here, one of the pieces I skipped over because it was in the wrong place. So Jim Henry, who was a researcher here, he had my job the first time it came up when the Institute opened. He had a grant called Community Activation for Health Research. And one of the things they did was to commission two deliberative dialogues about chronic pain. And so what happened with that was that, interestingly enough, we had trouble getting policymakers engaged. John Lavis was used to having policymakers lined up at the door to come and receive the information, and he could not engage people. This is in 2009, could not engage people within governmental policy bodies. 2 years later, there was a second one which brought a little different perspective to it, trying to get at those issues, but still very, very little in the way of policymaker engagement. So things go quiet for a few years until the Chronic Pain Network is working with the Canadian Pain Care Forum, and at the end of 2017, we commissioned a third deliberative dialogue from the Healthcare Forum. And the goal was to try and put together the structure of what might be an optimal Canadian pain strategy in a way which could be readily understood by policymakers. So it was a bit different than the questions that were put to the first two deliberative dialogues at a time when there was not a good solution and there wasn't a lot of support within the bureaucracy. So this was done. It was interesting. It gave us a document that we could take around as a draft Canadian pain strategy. And then I mentioned the opioid summit. So in 2016, as part of the response, so remember in 2014, the Canadian Centre on Substance Abuse First Do No Harm strategy came out, tried to figure out what to do with it. Health Canada was charged with putting a response in place, because remember 2014, then there's an election, so then we have a new government now. So 2016, Health Canada is charged with creating a response plan. CCSA was convening it, but the overwhelming bent of the first meeting in 2016 was on restriction of access and treatment of addiction. The pain community was getting progressively more distressed, and the Health Canada approached us in the Chronic Pain Network to say, look, you guys have a national network. Can you connect us with the people we need to talk to inform our strategy? We realize we have made a mistake. We've missed the pain objectives that were laid out by the CCSA. That led to an invitation to attend the opioid summit in the fall of 2018. And what was interesting about that was that this symposium was preceded by a roundtable with the Minister of Health, Jeanette Petitpas-Taylor, who herself has some sensitivity to the complexity of these issues, because she had been, interesting enough, in one of her earlier lives, she was a counselor with a shelter and an online support organization in New Brunswick, which frequently dealt with people who either had been abused or who had chronic pain problems, as it turned out, a lot of the call-ins. So she was aware of these issues and the complexity of them. She spent nearly 3 hours sitting at a table with about 20 people that they had selected to inform the discussion, and was very well engaged in this discussion. I was actually amazed. This was not a glib sort of, hi folks, pain's bad, have a good day. She was actually engaged and in discussion with the people who were presenting pieces of information to her. And you may recall, the public remarks that were made at the end of the opioid symposium. Minister of Health said, I am committed to exploring options for a national pain task force. And then in March, she carried it out. She announced this. So at the beginning of the Canadian Pain Society's annual meeting last March, she announced the creation of the Canadian Pain Task Force. So this task force, again, is a national body. The people in bold purple are on the task force. The blue names are on a bigger expert advisory panel, which actually has had several other people added to it. If you look through that, if you're familiar with the chronic pain field, you'll recognize many of these names. Maria Hudspeth, who's the co-chair of the committee, is the CEO of Pain BC, which is a provincial activist body, an advocacy body, which has just signed a contract with the provincial government to implement a provincial pain strategy. John Pereira is the immediate past president of the Alberta Pain Society. The Alberta government has just announced a pain strategy. Hani El-Gabalawi is the past institute director for CIHR's Institute for Musculoskeletal Health and Arthritis. Fiona Campbell, the other co-chair of the committee, is a pediatric anesthesiologist at Sick Children's Hospital and leads their chronic pain program, and she's also the co-chair of the Ontario Chronic Pain Network, which is supported by the Ministry of Health and Long-Term Care. Linda Wilhelm and Jacques Laliberté are patient partners who are also part of the Chronic Pain Network. And Manon Chouanière is a researcher at University of Montreal. But quite an august group. It was announced in March 2019, and they actually completed and submitted their first report on the state of the pain problem in Canada by June 2019. Very highly committed bureaucratic group, incredible support from the Secretariat. What they're calling engagement activities, they're going across the country collecting information about what works, what doesn't work, what are the challenges, what resources exist. So the public consultation process is underway now. Andrea Curry and Andrew Taylor, who lead the Secretariat, will be at tomorrow morning's Canadian Pain Care Forum meeting as part of their consultative process. The goal is to have the second report out in June of this year, and then the final report at the end of 2021. And although we're not permitted to call this a Canadian pain strategy, that's the goal. The goal is to have the pieces in place that a strategy could be implemented. There's some little governmental anxiety about having a bureaucratic body create a strategy when strategy is supposed to come from the political side. So there's an interaction between the elected politicians and the bureaucrats. I have been unendingly impressed so far with the folks in Health Canada that are charged with this. Their commitment is really remarkable. The areas of inquiry they're looking into is access to timely and appropriate multimodal care, awareness, education, and specialized training, pain research and related infrastructure, population health surveillance and monitoring of health system quality improvement. So all of the things that we had identified, all of the things that were identified by John Lavis's group in the deliberative dialogue and the evidence brief and the draft around the Canadian pain strategy. So all those things lined up to provide the information that offered Health Canada and potentially the politicians a solution which was workable. So the problem, as we all know, is that you can make federal policy around certain things. The feds are responsible for research through CIHR. Many of the educational bodies are nationally accredited, so you can drive accreditation there. But healthcare delivery is provincial. So in order to impact healthcare delivery, you have to get these issues onto what's referred to as the FPT table, Federal, Provincial, Territorial Discussion Tables. The provinces have to pick up on their pieces. The feds have to deliver their pieces. There's a whole issue of transfer payments and things like that. But interestingly enough, for a variety of reasons, there are provincial pain initiatives already underway, and you can see them here. Nova Scotia, I say Nova Scotia, but really, so this is 6 of 10 provinces, but Nova Scotia really leads the way, particularly for Prince Edward Island and New Brunswick. So that's a maritime unit. There's some crossover into Newfoundland. So we have most of the provinces represented. The only one I'm not certain about right now is the extent of activity in Manitoba, but there is good integration of their pain programs. So, as I said, BC, Alberta, both have announced strategies. Saskatchewan has something called Sask Pain, which has reported on what a pain strategy needs to be. Ontario, several years ago, put significant amount of money into supporting interdisciplinary care in pain clinics, but the university-affiliated pain clinics. So it was a bit of the problem is healthcare providers see this as a black pit into which money could be poured indefinitely with uncertain outcomes. So they're really anxious about what they will get if they try to fund things. So they started out with this initiative where university pain clinics were invited to submit proposals for how they would use interdisciplinary care. And so the Ministry of Health is currently putting about $25 million a year into interdisciplinary care at university-affiliated pain clinics around the province. Put that in perspective, they've also allocated $200 million for treatment of addiction, opioid addiction. So it's moving in the right direction for us. I was at a meeting today where we were talking about relative funding, and somebody pointed out that what's his name, Terry Jones from the Monty Python crew, who originated the 4 Yorkshiremen, who would sit around in a room and talk about how successful they had become and how hard life was as a child, and Oh, we had to walk to school both ways uphill in the snow carrying coal. Oh, you had coal. Oh. So we were all complaining about how bad life was. But one of the areas where the federal government is responsible for care are for the military, the RCMP, veterans, and First Nations. And so I find it interesting. I don't think it's entirely coincidental, but I also see it as an area where the federal government has taken the opportunity to show leadership where they have responsibility for care delivery, and that's in the field of veterans care. So earlier this year, middle of last year, July, the Minister of Veterans Affairs announced the creation of this Chronic Pain Center of Excellence, which is to focus on research, but one of its critical deliverables is to coordinate a national access for veterans to optimal chronic pain care. And this requires bringing together a chain of clinics across the country who will preferentially deliver care to veterans. And that process is underway. It's an interesting developmental process, I'll tell you. But so Ramesh Zacharias on the right of the picture here, he's the CEO of the group which is being developed. Beside him is a gentleman named John Brown, who's a Canadian veteran who went through the chronic pain program here at the DeGroot Clinic. And we have treated an inordinately large number of veterans, given that there are interdisciplinary clinics all the way across the country. We have been receiving patients from all across the country, which leads us to recognize the fact that there's a sort of an arbitrage problem here, where you have local resources, people are bypassing them to come here because we've set up a process where we will receive the patients and take them into our programs. And so part of our challenge for the network is trying to create local access also. But this is an area where the feds can pick up the torch in terms of delivering optimal care without infringing on provincial mandates to deliver health care. So that's kind of the summary. If I just let me back up for a sec, because I just figured out what I did with the slides earlier. So who else has done this? In cancer, there's a Canadian strategy for cancer control. There's a Canadian mental health strategy which is being operationalized now. It was announced about 2 years ago. And internationally, there's an Australian pain strategy. So the Canadian strategy for cancer control, these are one of the groups we went to say, how can we do this? So they have very specific goals, reduce Canadian incidence of cancer, enhance the quality of life, improve treatment so you're not so likely to die from cancer. They created a document which they submitted to Health Canada in 2006, which basically laid out a 5-year plan which has continued since that time. They're looking at $250 million a year to support a variety of things, including research, care, coordination of care, ready access to care. And one of the people that developed this, a guy named Bob Phillips, his granddaughter developed chronic pancreatitis, living in the Toronto area, and he could not access decent care for her. He could not get any sort of rapid assessment, couldn't get consistent opinion about what optimal treatment was. This puzzled him so much that he actually came to us to say, how can we develop a plan? There has to be a strategy. This is how we did it in cancer. So this was the message he gave us about the cancer strategy. First of all, you had to get a bunch of people together and make them work towards a common strategy. It has to be broad engagement, so it wasn't enough for the Canadian Pain Society in 2012 to come and say, we have a strategy. There had to be a lot of people engaged, including patients, but also Health Canada. So, and this was one of the bottom line here, early support of Health Canada is critical. Partly because cancer care was going to them with a clearly defined goal for what they wanted to do. Everybody had to be in support. So there's a little bit of the Monty Python reference, Life of Brian. If you've seen the Life of Brian, there's all the discussion about who really represents the freedom fighters of Palestine. And so what happened initially in cancer care was that every disease entity, prostate cancer, breast cancer, brain cancer, colon cancer, liver cancer, foot cancer, nose cancer, tongue cancer. Everybody had their own advocacy group, and everybody wanted money. And basically Health Canada said, forget it, go away, talk amongst yourselves, come back with one message. And that was a very important message for us, because we get a bit of the same thing in the chronic pain world. We actually have 3 groups in Canada called the Chronic Pain Association of Canada, the Pain Control Center of Canada, and the Canadian Pain Coalition, which went bankrupt, so they're out of the game now. But 3 bodies purporting to be nationally representative. You have to have data, so collecting the data is critical. That's complicated if you have a small amount of money allocated to pain research. And you also have to have a feasible strategy which is likely to make a difference. So we took that message away. We had spoken, many of you may know this guy, Michael Cousins. He is a past president of the International Association for the Study of Pain. He's been a leader in pain care and research for over 30 years. He's in Australia. But he brought together a group across the country in Australia. They have the Australia-New Zealand College of Anaesthetists, which includes a faculty of pain medicine, the Australian Pain Society, the patient group Chronic Pain Australia. They had good supporters. They brought a strategy forward which was implemented, and now is, I think it's about 7 years underway. It's had a 5-year evaluation which was able to demonstrate that the allocation of those resources had had a significant impact on improving pain care, access to pain care, moving people out of tertiary centers into the primary care level, providing rapid access. So, this was a message for us, and many folks have been to train with Michael Cousins or have met with him in other places, and he's always been available to advise how he went about his strategy. And then the other issue was the Canadian mental health strategy, which I have to go back and look at the organizational chart for this particular talk, because we seem to have done a random shuffle. But the Canadian mental health strategy, you may be aware, certainly we see a lot of ads now on television, supported often by Bell, about mental health. Just talk about it. Heard an excellent presentation on CBC this morning from CAMH with a woman who talked about how she had developed a mental health problem in her workplace. Fortunately, even though there was no workplace plan or system for dealing with it, she was able to work with her physicians and her workplace, resolve her own mental health issues, effectively return to work. And CAMH has now developed a set of guidelines, a little how-to book for employers on how to identify and appropriately resolve mental health issues from an employer standpoint, which doesn't mean treating mental health. It means accepting the fact that mental health is a disease which can be treated, and then people can come back to work. And it was really neat, but the talk was really interesting. But it brought to mind the fact that happened because of a mental health strategy, which again was developed by broad-based engagement across the country, and it incorporated support from industry. So, breast cancer has the Royal Bank of Canada, RBC. They have their fundraisers. Mental health currently has, a number of, interestingly enough, a number of sports, famous athletes have come out to talk about struggles with mental health in the course of their training. That's created public awareness. And industry like Bell Canada, for example, has supported the advertising, the dissemination of awareness and the hope for a control strategy. So 3 really good examples. And I think that what we're able to do now, what we're able to say now about the Canadian pain strategy is that having had those things in place, we have now gotten far enough ahead that we can check off some of those other boxes and say that we now have engagement of Health Canada. We have a potential solution in place. We're bringing people around the table to take the Canadian, to develop a Canadian pain strategy through the activities of this Canadian Pain Task Force. So that's sort of the background. I just find it interesting to be able to track those, because I've seen most of this go on. Have been actively involved in some of it and an observer for others, and it's really interesting to see. So thanks for your time and attention. I'm going to open up for questions now, and I think I'm going to open up for questions. Maybe I won't. Aha, the iPad battery is toast at just the wrong time. Well, I apologize to the people online who may be trying to send me questions. What I'll do is when I battery up the iPad later on, I will email responses to your questions. Anybody in the room have any questions? Or do you just want to go to the concert? So, because.
Kind of like coming back to the Australian model, because they have rural areas, obviously underserviced areas versus urban areas. So I'm sure this strategy, like you're talking about having a unified voice in one kind of messaging, but it'll likely be, it's multifaceted in that you probably have certain circumstances where you need a different strategy, let's say somewhere in Northern Ontario and Southern, and then also would there be differences also regionally, so Eastern versus Western Canada? Like, with this strategy, encompass everyone's needs, because you know one of the issues is that you need to make it simple, but it's hard to apply it and make it different.
The part of the goal of the task force is to identify the resources that are available, and the places where they have not rolled out effectively, to find out how you can match those things. So, for example, if you need hands-on care, if you need an intervention, you have to come to somewhere where the intervention can happen. But assessment could happen at a distance through various telehealth networks, or support for family physicians to deliver care in their own practice can happen in a number of ways. There's a couple of e-consult programs running now where family physicians submit questions to a specialist, and not just in pain, but in a variety of areas. But they can get the advice that allows them to manage their own patient in their own practice still. There are mentorship networks. Ontario has one run by the Ontario College of Family Physicians called Medical Mentoring for Addictions and Pain, and it's combined with several other mentoring programs, like community mental health, for example, where physician mentors are identified who then are responsible for a stable of mentees who come to them. They may have group discussions, they may be readily available by telephone consult and things like that to advise around managing patients in their own practices. The Project ECHO, which is it's a telehealth. It's a combination of didactic education and case management. So what happens is in an hour to 60 to 90 minute long session, there will be delivery of some didactic lecture on some aspect of pain, in the pain ones in particular. And then there's an interdisciplinary table of experts available, and the physicians who are signed on to the ECHO program submit their cases in a standard format. They're discussed around the table. They get advice about how to manage them. They take them away, and then they come back, several weeks or months later to report on the progress, challenges, monitoring, things like that. That program the original Project ECHO was actually for managing hepatitis C in New Mexico. And it turned out that when they did that, they were able to decant the management of hepatitis C away from the one tertiary care center in New Mexico out into clinics in the communities. And the results of the community clinics were actually better than the results of the tertiary care clinic. And part of the interpretation was that more patients engaged in the treatment, and because there were fewer hindrances to treatment, you didn't have to drive 6 hours to the hospital in Albuquerque. You could be treated in your home clinic. You had ready access. That their clinical results were as good and their uptake was better. So the concept was rolled out into a number of other areas. And so the idea there is that you both educate your clinicians and you make care more accessible with fewer barriers. As you know, in the clinic here, we have access to the Ontario Telehealth Network for distance consults. And there are different bits of technology, and some of it works more or less well, but when it's working well, what we're able to do is, I mean, I saw a patient in Napanee the other day for 15 minutes, and that's all of his time that it took. He sat in his car, he came off the job site, sat down in the car, called in on his phone to the OTN site. I tapped in from my office onto the OTN site. I did the follow-up that was necessary, and he went back to work. That would have been a day lost work for him otherwise, because it would have been 2.5 to 3 hour drive from Napanee to Hamilton and then back. So, so the solutions, some of them are there, some of them may need to be developed. And the expectation is that the task force, if they can identify the solutions and where the resources are, similarly for research, sort of 0.008 of the annual CIHR budget is devoted to pain research. So given that it is $60 billion a year is actually more than it costs for either cardiovascular disease or cancer in terms of the impact on people, partly because chronic pain has an impact over years. A lot of really nasty diseases kill people quickly enough that they become less expensive. I mean, it's a nasty way to say it, but if you die quickly, that's not expensive. Even if you spend a lot of care money in your last weeks or months, it's still, you're done. Whereas chronic pain has an impact. If it takes people out of the workforce at 40, then you've got 25 years of disability coverage, no activity, no tax generating income, and your quality of life is significantly reduced. So given the magnitude of that problem, we would like to see more research dollars allocated, and we're hoping that the task force makes that point, and that information becomes clear to the policymakers in CIHR, for example. Other questions? Yeah.
Sam,
Yeah.
you touched upon OTN, particularly with that. I know the pain clinic up here is going to try to get it up and running more.
You're volunteering in the clinic. Yes. You're that Sam.
So, essentially, I'm wondering if the task force has sort of, that's been a topic of discussion, telemedicine and the effectiveness of that.
Yeah. If you Google Canadian Pain Task Force, it'll take you to a Health Canada website which has the link to the PDF for the first report, which, as it turns out, is actually a fairly readable report, and it's not too arcane, and it's actually written in comprehensible English. And that will tell you the things that they've identified, but certainly telehealth is one of the things that has been identified as a potential resource. It's still, if you only have a small number of pain consultants, you're still limited by the number of pain consultants you have, but at least you can save patients driving. And so like our clinic here, our catchment area goes from Niagara Falls till sort of halfway up the Bruce Peninsula. So you can be easily 2.5 to 3 hours drive from the clinic. So if we have a straightforward follow-up, check on information, renew medication, for example, if that's that could be a 15-minute visit, and I just saved you 5 hours. And in some ways that catches a patient's attention. It doesn't really catch a policymaker's attention because that didn't cost them anything. It might catch an employer's attention because you may have had to take a day off work to come to clinic. On the other hand, if you're on disability from a workplace accident, or if you're on Ontario Disability Support, for example, they have an obligation to cover your travel to necessary medical care. I'm told that a cab from St. Catharines to here is about $140. So if we can eliminate, $300, well, 140 times 2, $280 worth of travel expenses, that can go into another part of the budget. I'm not sure how big a budget ODSP has for travel, but I'm sure it's more than nothing. So there may be savings in different, this is where the business of siloing budgets comes in. What we found interesting at the first meeting of the Canadian Pain Task Force back in May, I guess, or the first meeting of the task force itself, the 8 people on the task force, was in April. But we had the first meeting of the whole group, including the advisory panel, in late April. And there were not just Health Canada and the Secretariat there were at least 6 other either ministries or other government bodies in attendance because pain was an issue for them. So the people who are responsible for education, they need to know if they need to modify their, their calls to the people they give money to, and we think they do. Corrections has a significant issue. How do you let's say, for example, that opioids are in fact the right thing to do for a certain proportion of patients who have chronic pain. If that patient goes into prison, how do we manage that without that patient becoming target for people trying to steal medications or convince them to divert medications and things like that? How do we just get the appropriate care to them? So corrections is very interested in how to manage pain in their context. Police forces want to know what's appropriate medical care so they can, so if somebody is stealing money to get drugs, how do they divert them into the right treatment plan so that, one of the things, I was involved in disseminating the Canadian opioid guideline to some groups, including law enforcement agencies, and one of their repeated questions has been, we keep arresting addicts because they steal money to get drugs. If you're telling me addiction is a disease, why don't you just give them the freaking medication? And then we don't have to arrest them. They won't kill people. They won't rob pharmacies. They won't steal stuff to get money. Just treat them. It's really interesting. I mean, that's an interesting driver to have in the whole treatment discussion. So why should we make police arrest addicts when, if we actually believe that it's a disease, we should treat the disease? So, there's some really interesting conversations that go on around those things. Yeah.
I understand there are some pain research projects going on at McMaster. Are there enough resources available to carry on these projects?
Well, we have a number of things, so within the, specifically for pain research, the Michael de Groot's endowment funded the Michael G. de Groot Institute for Pain Research and Care, which keeps me occupied. But we have a significant budget. We live off the endowment, which is about a $15 million endowment. So our annual budget it's over $1 million, and most of that is directed towards research. Some of it's directed towards support for the administrative activities, but most of that budget is directed towards research, either graduate stipends, postdoctoral fellowships, or seed grants for specific research, as well as supporting some of our budget is dedicated to the matching fund component of the SPORE grant. So so within the institution here, we're seen as pretty fortunate amongst pain clinicians across the country because we have access to that kind of money. We could always use more, but our researchers have also been pretty successful in getting competitive grants. Particularly Jason Bussa, for example, who's an epidemiologist and a chiropractor here. He's been very successful in he has actually one of the largest clinical trial grants for it's looking at the impact of CBT in improving recovery from open tibial fractures, which is a problem which is seen to have significant implications for failure to recover to full function because of chronic pain complaints. And one of the predictors is the expectation and attitude of the individual who's injured around their likelihood of recovery. So the thought is, an attitude or an expectation or a belief may be subject to modification through the application of cognitive behavioral therapy. So they have a $2 million grant over about 4 years to carry out a trial to see if you can, in fact, modify those beliefs in a way that leads to improved outcomes, because we do know that those beliefs are a significant predictor of poor outcome. So, there's never enough money, but we're doing better than most, I think. Okay, I'm pretty sure that the distance thing went off, but we're still here, so, yeah.
Do you know of any initiatives that are being taken on like the educational front in terms of tackling the pain problem? Like in terms of like professional schools and how we should educate like new professionals coming into the field to deal with like the chronic pain problem?
As it turns out, I do, yes. So there are several of them. One, as much as I hate to say this, the University of Toronto has actually a very good interprofessional education program around chronic pain. They have the advantage of, because they have a highly structured program, and they have a number of professional schools there. So they have pharmacy, they have social work, they have nursing, they have medicine, they have rehabilitation science, they have dentistry. Did I say pharmacy? I think I said pharmacy. So they have a 2-week program where they bring all of the schools together because the interdisciplinary interaction piece is thought to be important, and I believe it is. And they go through a combined sort of didactic and problem-oriented education program. So in 2 weeks, what's that? 6 hours a day times 10 days, that's 60 hours. That's almost 4 times as much education as the average medical school program in the country allocates to pain education. And they just do it in a 2-week block. In fact, the last time I saw them, they're claiming 90 hours. So they either run longer days or they do something else as well. But so that's one program that exists. And one of the things that we funded in the Chronic Pain Network is the plan to disseminate that to other health professional educational institutions across the country. The Association of Faculties of Medicine of Canada, so the AFMC, as part of its commitment to the Opioid Summit, agreed to review curricula for addiction and pain amongst all the 17 medical schools in the country, and then institute a program to establish and improve curriculum in those fields. The assessment process was completed and identified the thing that every pain researcher in the country already knows, because we've heard it for 10 years, that there's around 15 to 18 hours of undergraduate medicine education which can be mapped in any way, shape, or form onto the International Association for the Study of Pain's curriculum for pain education for undergraduate physicians. So the AFMC has taken it upon themselves to change that and develop a better curriculum, and because the AFMC is part of the accreditation of medical schools, that will be a driver for changing medical schools. Nursing has done something similar, but I was trying to get somebody to give us a talk about it for another meeting, and I'm not sure where they are right now. Pharmacy, interestingly enough, I've done a bunch of continuing education things for pharmacy groups. The pharmacy program up at Waterloo was that we did a pilot program about 6 or 7 years ago that involved social work up in Waterloo, undergraduate medicine, the nursing group in Waterloo, and the pharmacy group. And so we did it was a series of sort of 2-hour sessions on Wednesday evenings for 4 weeks, I guess. And we ran it for several years. We had pretty good response. And so the pharmacy school was, in fact, the most interested. And because of their schedule, they were also the most able to take advantage of the program. So the short answer is yes, there are things going on. I know of some of them, but again, some of those will be in that the task force report if you want to read it. It's actually, as I say, it's readable. Okay, I actually have another meeting to go to now. Thanks very much for your attention. Much appreciated.